Thank you very much for your introduction, Mr. Chairman, and good afternoon to you all. In the following 20 minutes, I will discuss perianal anatomy and imaging techniques. And I will do that. I will make you firstly understand anal canal anatomy. Secondly, I will try to make you familiar with state-of-the-art protocols for imaging the anal canal. And thirdly, I will try to learn you a little bit about normal variants that mimic anal disease. So then we'll proceed to the anatomy, and then you'll see a schematic drawing of the anal canal. The inner layer of the anal canal consists of squamous and columnar epithelium. And with the transitional zone between those two types of epithelium at the dentate or pectinate line. Here's the rectal mucosa, the pectinate line, and below the pectinate line is then squamous epithelium, and the rectal mucosa is columnar epithelium. Then you have the muscular component of the anal canal. And these consist of an inner layer of circular smooth muscle. This is the internal sphincter. And then an outer layer that consists of striated muscle. And this is caudally the external sphincter, and cranially of this external sphincter, the puborectal muscle. And you see here the circular smooth muscle. So this is the circular smooth muscle of the rectum. And then when you follow this until the anus, you see that it becomes the internal sphincter. And then here you see the striated muscle. That's the external sphincter. And then indicated on the right side of the image, the puborectal muscle. And you see it's on the cranial side of the external sphincter. And then between the internal and the external sphincter, you have the intersphincteric space. And this is not a virtual space, but a fat-containing space. And in this space are also smooth muscle fibers of the longitudinal muscle of the rectum. And you see it here. You see the longitudinal smooth muscle, and then when you follow it downwards, you see these fibers here between the internal sphincter and the external sphincter. And then, lastly, outside the anal sphincter is the fat-containing ischioanal space. In a lot of reports, it's also called the ischiorectal space, but I like to call it the ischioanal space as it surrounds the anal canal and not the rectum. So again, just to repeat it, a schematic drawing, again, of the sphincter, where here you see indicated the internal anal sphincter, the external anal sphincter. Here you see the intersphincteric space, the fat-containing intersphincteric space, with the longitudinal muscle fibers. Here you see the puborectal muscle cranially of the external sphincter. And then this is continuous with the levator plate on the cranial side. So then we continue to the imaging of perianal fistulas. An evaluation of these, be it either preoperatively or postoperatively or without an operation inside, is very important. What you need to do is to determine the relationship between the fistula and the anal sphincter. And you need to determine the extent of disease. And this is a literal citation from the article that you see below from Schubert. In this article, it literally says, the importance of accurately characterizing the fistula tract prior to therapy cannot be overemphasized. And why is that? Incorrect classification of fistulas and determination of the extent of fistulizing disease increases the risk of incomplete healing of fistulas or of recurrent fistulizing disease, and also, and this is a very important point, of inadvertent sphincter injury, where you can if the surgeon divides too much sphincter, the patient becomes incontinent. For many years, examination under anesthesia has been considered the gold standard for evaluation of perianal fistulas. And, well, the title has already said it, but this is performed under general anesthesia. And what the surgeon does is a visual inspection, palpation, digital palpation, and a passage of malleable probes into fistular tracts. However, this is not a 100% accurate examination. It is stated that it's approximately 90% accurate in detecting and correctly classifying fistulas, sinuses, and abscesses. And also, this was stated in a review that was published in Radiology in 2006, it's associated with a high recurrence of fistulizing disease because extensions are missed in a high rate, up to 25%. And as then examination under anesthesia was an imperfect evaluation method, many research has been conducted to see whether MRI and endo-anal sonography are well suited to assess perianal fistulas. And Siddiqui and colleagues performed a review that was published in 2012. And in this article is stated that the sensitivity of MRI and endo-anal sonography are comparable, both 0.87%. Whereas the specificity is for both techniques lower, but for MRI it's 0.69, and for the sonography it's 0.43. Another, a slightly older review by Sani, 2008, says that in this article, MRI, sonography, and clinical evaluation were compared. And you see here in the upper row are the sensitivity and the specificity for MRI, and these are very high, almost 100%. And then the second row, the sensitivity and specificity for sonography, and you see that's a high sensitivity for endosonography as well, and a slightly lower specificity, but still very, very acceptable. Well then, endo-anal sonography is a simple and a fast technique. It's generally well tolerated by patients. And what you do is you have a rotating probe that has a 360-degree radius. This probe is covered with a sonolucent cone that is filled with water. The frequency of the probe, as described in the literature, is between 5 and 16 megahertz. And what is done is that the probe is inserted in the rectum gently, and then it's slowly withdrawn so that you can adequately visualize the sphincter complex. What can also be done, additionally, is infusion of hydrogen peroxide in the fistular tract for better conspicuity. And then some articles say that the lack of the use of it results in suboptimal results. But that's not stated in all the articles, though. However, there are some major drawbacks to the endo-anal sonography. Firstly, it's highly operator dependent. Then it also has a very limited ability to resolve ischioanal infections, as well as fistulas and abscesses that extend cranially off the levator plate. And then also there's no reliable distinction between infection and fibrosis, because infection and fibrous tracts both are hypoechoic, so there's no distinction. And then MRI. MRI, of course, has a wider field of view than sonography, which makes this technique more suited for assessment of complex branching tracts. Also better suited to evaluate lateral extension in the perianal space or in the ischioanal fossa, as well as cranial extension above the levator. With MRI, you could either use an endoluminal coil or a phased array body coil. And an advantage of the end-aluminum coil is that you have a very high spatial resolution. And this means that you can precisely demonstrate the location and the height of the internal opening. Also, demonstration of anal or rectal vaginal fistulas is good using this technique, better than with a phased array coil. And lastly, the use of an end-aluminum coil is valuable when you need simultaneous information on a degree of sphincter disruption. Then the phased array surface coil. These have a high spatial resolution as well, have a superior field of view when you compare with the end-aluminum coil, and are definitely more comfortable for the patient. I'll show you some images, both with the external coil and the internal coil. And on the right-hand side, you see the images with use of an end-aluminum coil, and on the left-hand side, the images used with use of a phased array coil. And then you see the external sphincter, so the hypo-intense external sphincter. And here you see it as well, nice ring-like structure. The relatively hyper-intense internal sphincter, also nice complete ring. And then the intersphincteric space. And then you can appreciate it on the phased array images. Well, you know where it should be, but you cannot see it. And then when you use the internal coil, you can even see the fat in the intersphincteric space. So definitely a higher spatial resolution. These are images that are at a slightly higher level than the ones that I just showed you before. And again, you see the hyper-intense internal sphincter. And here we are at the level of the puborectal muscle, so the puborectal sling, so above the external sphincter. You can nicely see it here, and here the sling-like appearance of the puborectal muscle. These are coronal images, again, phased array and in endo-luminal coil. Here the external sphincter, hypo-intense. The hyper-intense internal sphincter. And here, better delineated with the internal coil, but also nicely visible with the phased array, the puborectal muscle. And then cranially of those, the levator muscle. And of course, outside of the anal sphincter, the ischioanal space. So what imaging protocol should you use for MRI? You should perform T2-weighted turbospin echo sequences in 3 orthogonal planes, as these provide an adequate contrast between the different sphincter components, as you just saw. And as well as providing adequate contrast between these sphincter components, there's also a good contrast between the hyperintense fluid in a fistula tract and the hypointense fibrous wall of the fistula. What you should do is angulate your axial and your coronal sequences at the anal canal. And it's done because you need to image in surgically relevant planes. This is an older image, so it's not, the resolution is not so high, but it's just to show you, do not angulate like this, so at the rectum, or just go straight down. Angulate at the anal canal. Additionally, a fat-saturated T2-weighted sequence is recommended for optimal conspicuity of inflammatory changes. You can see them on your regular T2, but they're much better visible on a fat-set sequence. And you can well appreciate it here. On the left-hand side, your actual T2-weighted sequence with an extensive, it's an abscess actually. So it's also a transsphincteric fistula, but I have not depicted that. But it's also a large abscess. And you can much better see it on your fat set image, and especially when you have your fat here on the right-hand side in the right ischioanal fossa. Of course, you can see that there's fluid here, but you can way better see it on your fat set image. And then optionally, you can perform post-contrast fat set T1 weighted imaging. And this is helpful if you want and you need to differentiate between an abscess and inflammatory changes. And again, you have here, on the left-hand side, an actual T2 weighted image where you see a collection, a hyperintense collection. And in it is a ceton, that is hypointense. And on the fat set, you still see, as it is a T2, and supposedly it's fluid, you still see a hyperintense collection. And then after administration of contrast medium on a T1, you still see a completely hyperintense collection. So this cannot be pus, because pus would not enhance. This is purely enhancing granulation tissue. And then I have, to illustrate this further, again, the same large collection that I have shown you before on the actual T2 and the fat set T2. And then this is an image of this patient after intravenous contrast medium. And you very nicely see that this area on the right anteriorly of the sphincter shows a lot of granulation tissue, but there's also a large amount of fluid. So this is not granulation tissue. So this is a very busy slide. This is the protocol that we use at the Academic Medical Center in Amsterdam. But it's just to point out that we do practice as we preach. Namely, we do T2 turbospin echo sequence in 3 orthogonal planes. We do a fat set T2. And we also do a post-contrast T1 weighted fat set. And we do that in a transverse plane. Well, then, if you compare the relative advantages of endoanal sonography versus MRI, they both are very good when you need to evaluate simple fistulas. For complex fistulizing disease, MRI is a little better. For high tracts and abscesses, so above the levator plate, MRI is better. The internal opening is better visualized at endoanal sonography because of the higher spatial resolution. Well, standard equipment, that's the advantage of MRI. You need no special device, and there's not the burden of an endoanal introduction of this special device. And then the costs. Well, an MRI is available, and for the sonography you need special equipment and a dedicated practitioner, so it's a little more expensive. And then the availability, of course, this varies because MRIs are often booked fully, but then on the other hand, in many hospitals you do not have people who can perform the endoanal sonography. And then comparable results. Well, as I already have shown in the literature, MRI provides just a little better. So basically, MRI is the favored technique for evaluation of perianal fistulizing disease. And this is also stated by the European Crohn's and Colitis Organization in one of their statements, where they say that MRI is the most accurate diagnostic imaging tests with an accuracy surpassing examination under anesthesia, and it's recommended for the initial diagnosis of perianal Crohn's disease, unless a need for immediate drainage of sepsis exists. And then endosonography is superior to clinical examination and is an alternative to MRI. And another statement by the echo is that undetected or untreated fistula extensions and abscesses are the major cause of treatment failure. And imaging, particularly MRI, is highly accurate in detecting such complications and for treatment planning. And then lastly, I would like to talk to you very shortly about the mimics of perianal disease. Well, intersphincteric infection is the principal feature of perianal fistulas. And this is generally not found in other conditions. A pilonidal sinus may resemble a fistula, but intersphincteric infection should not be seen. So this is very helpful to discriminate between these two. And I have included coronal images of a patient with a pilonidal sinus. And you can see it here, where you can see a hyperintense tract that abuts the external sphincter, but at no point was there any extension in the intersphincteric space, and this was a pilonidal sinus. Another mimic is veins. They can be mistaken for fistulas. However, veins are thin-walled, they are tortuous, and they are symmetric. And then lastly, hemorrhoids and anal tags. They could resemble small submucosal fluid collections, but the surgeon or the gastroenterologist should easily diagnose these at clinical examination, so there should be no confusion about these. Thank you very much for your attention.